My name is Rich Mickelson. I'm the manager of the cardiology services here at the clinic. Again, I appreciate everybody's interest in today's topic and, like I said, making it here through the weather and the roads, and thank you very much for coming. It's my pleasure to introduce today's topic and panel. Our main moderator is going to be Dr. Kristen Scott-Tillery, which some of you probably know. She's been with us since 2011. Finished up her cardiology fellowship out of St. Louis, Missouri, and then recently did an advanced heart failure fellowship, heart failure and transplant down in Salt Lake City about 2 years ago now, correct? Yeah, correct. Joining her, she'll be moderating today's lecture, which will be sort of a panel discussion and lecture on living with heart failure today and some of where we are with today's technology and advancements and treatment guidelines. But with her will be Cynthia Gary. She's our clinical pharmacist within the heart failure team. Lisa Grozzi. She is our certified heart failure nurse within the heart failure team. And also joining us will be Dr. Colin Fisher, who's also a general cardiologist here at Billings Clinic. He's been with us since 2015, did his fellowship in cardiology at Walter Reed Army Medical Center. So without further ado, I'll let Dr. Scott-Tillery get on with today's lecture. She'll lead through some slides and some lecture, and then we'll have some topics from there. Thank you, everybody. Actually, before I go, I'm going to do welcome the telemedicine sites today. I do want to remind the telemedicine sites to keep their speakers mic'd until time for question, but on with us are sites from Cody, Ekalaka, Glasgow, Glendive, Lovell, Malta, and Lewistown. So welcome to you guys that are hooked up via telemedicine.
Okay. So I'm Dr. Scott-Tillery. I know a lot of you. I see a lot of familiar faces out there. So what I want to say is that I'm so glad that you guys came. This is a really important topic, obviously to me, because it's what I do. But it's a really important topic just in general because of the prevalence of heart failure. And I feel like it's one of those things everybody understands what a heart attack is, right? You kind of have that. You see it on TV all the time. But what is heart failure is a little bit more challenging of a question, and I think we need to spend a little bit more quality time with it. The first thing I want to say is that two of our panel members that were supposed to be here today have been called away by the flu or by personal circumstances. So some of this we're going to kind of improvise a little bit on who gives the presentation, but I think we're going to give you all the information that you need. Okay? So the first thing we're going to talk about is that the most important thing that makes heart failure work as a treatment is a team approach. And if you look at all of the big centers all over the country that are treating heart failure, they have this team approach where multidisciplines come together and help the patient. So the patient doesn't just have a doctor. They have a doctor, they have a set of nurses, they have a pharmacist, they have a social worker. And all of these things come together in a way that helps the patient really be able to navigate the system and do well. So I'm not going to give you a big lecture on what is heart failure, but I want you to understand the basics. And I feel like if you can understand the basics of physiology of what's going on with heart failure, come on in, Dr. Fisher. Then you can understand what's happening and understand symptoms and things like that. Okay. All right. So simply, let's just boil it all down. You know, you can take 5 years of medical school and residency and all of that and boil it all down to what is heart failure. It is the heart unable to pump enough oxygen to the tissues that need it. Okay? So the tissues that need it would be things like your kidneys, your brain. So, you know, you might not be thinking as clearly, or you might be very tired. You don't get enough oxygen to your liver, and you start having liver issues. And then those organs start to fail. So that's really the definition of heart failure, is an inability to supply oxygen where it needs to go. There's many different pathways that will get you to this point, but if you just understand that, it doesn't really matter which pathway you go down to get to heart failure, but this is the end result. Okay. So some of you out in the audience might be thinking, well, you know, what exactly is this? And I know that I just heard it out in the audience, that every time I go to the cardiologist, I always ask, what's my ejection fraction, right? So the heart has two things it has to do. So first thing it has to do, it has to squeeze. So the blood that's in the heart has to get out of the heart, right, to get where it needs to go. So if a heart is doing perfectly well, the ejection fraction, or how much blood is pumped out with every heartbeat, should be 50 to 55% or more. So that would be normal. So one type of heart failure is when the heart cannot do that. So instead of pumping out 50%, it pumps out 30% or 20%. And you can see where that would cause, lack of oxygen to where it needs to go. But the second type of heart failure is when the heart can't do the second thing it has to do, which is relax. Okay? So most people think, oh, relaxing, that's no biggie, right? But it actually takes energy for the heart to relax. So a normal heart, it squeezes, and then it doesn't just relax and fill, it pops open. And that popping open causes negative pressure, and the blood gets sucked into the ventricle. So that's how it works normally. But for some folks, their heart muscle gets stiff, and they don't have the ability for that heart to spring back open. So even though it's a completely different mechanism, it causes the same end result, which is oxygen's not getting where it needs to go. Okay? Does that make sense? Okay. Okay. So the problem with this, right? So the problem with either the heart not being able to pump, so you can't get enough blood out, so when the next amount of blood comes in, there's too much, or it can't fill, and so the blood's trying to go in and it can't get in there. Both of them cause elevated filling pressures, and that's the problem, right? So it's not whether or not the heart is pumping, because some hearts, even though they don't pump very well, don't get into trouble with elevated filling pressures. But it's the filling pressures that cause the heart failure. What it causes is it's a backup of fluid. So it can't go forward, so it goes back. And when that fluid goes back and those pressures go backwards, that's where we get into trouble with symptoms. Okay? What are the symptoms? Well, the ones that we always talk about with our patients: swelling. Are you having any swelling in your feet and ankles? Some people swell in their feet and ankles. Some people swell in their bellies. Everyone's a little bit different. Okay? Do you get fluid in your lungs? So can you lay down at night and go to sleep, or does it feel like you're drowning because when you lay down, that fluid's in your lungs? Do you get short of breath doing things that you should be able to do? So 2 weeks ago, you could go to the grocery store, carry your groceries in, climb the stairs, or what have you, and now you can't. You have to stop and rest, catch your breath, or other things that you do, just basic exercise tolerance that you can't do. Those are the biggest symptoms of heart failure. Okay, just a little bit on who gets heart failure, because I think this is very important. 1 in 5 of you guys will get heart failure in your lifetime. Okay? There's no predilection for women versus men. They're the same. Women tend to get heart failure later in life, and they tend to get more of the heart failure that you can't relax the heart. Whereas men tend to get heart failure earlier, and most often that heart failure is weak heart, and most often it's from coronary disease or having a heart attack. Okay. So why do you get heart failure? So these are just some of the reasons, the most common things. So heart attack, most common. There are viruses that cause heart failure that you don't even know that you ever had. You were sick, and then the next thing you know, you've got swelling in your feet and ankles and you're short of breath. Toxins, unfortunately, very commonly here in Montana with our younger folks, we're seeing methamphetamines is a very common reason for heart failure. Stiffening of the muscle that we talked about, that can't relax. There are lots of different things, especially as we age, things that get deposited within the muscle that make the muscle harder to relax. There are a lot of genetics involved. Interestingly, I have one patient that I talked to who had a new diagnosis, and during the conversation she said, oh, well, my sister had a heart transplant 5 years ago, and oh, my brother has been diagnosed with a weak heart as well. So we know there are genetic things going on, but we're not 100% sure what they are. There's a lot of research into that area right now. And then a whole host of other things. Okay, just quickly, how do we prevent heart failure? So this is kind of the generic talk that every cardiologist gives, because really all the cardiac risk factors lead down to the same things. So they either lead down to having a heart attack, they lead down to having heart failure, right? So risk factors, the most important risk factors, high blood pressure, okay? They call it the silent killer for a reason, right? Nobody really can feel it, or if you can feel it, it's way too high. And people don't necessarily treat it as aggressively as they would treat something like diabetes or something like that. But it's one of the most important risk factors for getting heart failure down the way, especially the stiff heart. Because if you think about it, the heart's a muscle. And like any muscle, like your bicep, if you ask your bicep to lift more weights, that bicep's going to get bigger and going to get thicker, right? Well, the heart is a pump. And if you ask that pump to squeeze against a higher pressure over time, that heart's going to get thicker, and it's going to get stiffer, and it's going to get harder to relax, leading to heart failure. So high blood pressure, really important. Then your other things that you always hear from the cardiologist: diabetes, cholesterol, making sure you exercise it, eat right. Okay? All right. So how do we treat it? And again, this is where we talk about our team approach, right? So we're going to kind of go through this, and a couple of our members are missing due to the flu and such. So we'll fill in what other things we need to talk about there. But our team usually is a physician, a pharmacist, we have nurses, we have social work, and really anybody else that we need to pull in. So if anybody has a special need or a problem or a barrier that we need to pull somebody else in, we do that. So what I want to talk about to put this all together is a case. And we have a very gracious patient who was willing for me to use his case and to kind of walk you through all the steps of how we treat heart failure from really beginning to advanced therapies. And I have to appreciate very much that he's here and he's in the audience with us. And we're going to talk about his case generally. I'm not going to give you a lot of details, but I'm going to walk you through it. Okay, so this is Mr. W.R. He's a 58-year-old gentleman. And his story really began about 6 years ago when he presented with symptoms for the first time. So shortness of breath, swelling, all that kind of stuff, decreased exercise tolerance. At that time, they found that he had a weak heart. So he's one that has a heart that doesn't squeeze as strongly. Okay? So his ejection fraction was low. Why did he have heart failure? We don't know. This is one of those other causes. I don't know what it is. We may never find out exactly what caused it, but no matter what causes it, we go down the same pathway of treatment. Okay, so at this point, we got him, and we started to initiate medical therapy. So right now, I'm going to have Cynthia, our clinical pharmacist, kind of talk about what our medical therapy is and how we take somebody that's sick and make them feel better. Okay? Take it away. Do you have I'll give you the next slide.
All right. Thanks, Dr. Scott Tillery. So with heart failure, there's several medications that we do have to treat it. And those are all really kind of targeted towards reducing those, kind of relieving those increased pressures in the workload of your heart, like Dr. Scott Tillery was talking about. So first, there's diuretics. So diuretics, also commonly known as like water pills. So those diuretics like furosemide and torsemide, they work in your kidneys to kind of increase the excretion of excess water and sodium from your kidneys. So you'll have increased urine output, and that helps to really relieve congestion in your body and decrease the amount of fluid.
So you're basically talking about symptomatic relief with diuretics.
Yes, so with diuretics, so relieving that congestion, so that's going to help you feel better. It'll help with your symptoms as far as that shortness of breath and swelling that you can have in your legs or belly, like she was talking about. And then all these next medications are, kind of have specific targets that work to reduce kind of the negative effects of hormones that are increased in your body with heart failure. And I get excited about these medications as a pharmacist because there's just a lot of data and clinical trials that they really help reduce your risk of death and hospitalizations with heart failure. So the first one is beta blockers. So beta blockers like metoprolol and carvedilol are, common ones. that we use in heart failure, and those ones really work to, they work on blocking beta receptors on your heart to decrease heart rate, and they also decrease blood pressure, so kind of relieving that excess pressure and workload on your heart. And then we have ACE inhibitors, which are angiotensin converting enzyme inhibitors like lisinopril or enalapril. And a similar class of medicines to these are what we call ARBs, which are angiotensin receptor blockers. So both of these and those are like losartan and valsartan. So both of these types of medications work to decrease the effects of a hormone called angiotensin 2 in your body, and that results in your blood vessels widen. So if your blood vessels are widening, we decrease blood pressure, and then your heart has less pressure to pump against. So it kind of helps. And then they have other effects like the beta blockers and the next medication we'll talk about to kind of overall help with decreased negative remodeling that can help that happens in heart failure. And then last up there is the aldosterone antagonists. So these are medications like spironolactone and eplerenone, and they work, antagonist means to block the effects of, and so they're blocking the effects of aldosterone in your body. And so what that will do is kind of block excess, having your body hold on to extra fluid and sodium, and then also work with the other medications to help decrease that negative remodeling. So all these medications, over time can help improve your heart function and help with your symptoms. And there are certain target doses that we have for heart failure treatment that we try to get patients on. So those are the doses that have been studied in the trials. So we kind of try to work towards those medication doses. Sometimes this is limited by side effects. So all these medications do have side effects. So if you're having any side effects like dizziness or other problems, be sure to let one of the team know so we can take a look at your medication list together and see if there is alternatives or a dose adjustment that can be made to help. And so those are like the main classes of medications. And how many of you guys have seen the commercial for Entresto? Yeah, so that's a newer heart failure medication. So it's a combination of that contains valsartan, which is one of the ARBs, one of the angiotensin receptor blockers, and it is combined with kind of a new medication called sacubitril, which has a novel target to inhibit what's called neprilysin in your body. And together they work similarly to the other heart failure medications to decrease blood pressure, decrease fluid overload, and all of those things. And really this medication is it's good for heart failure patients, but it kind of depends on your symptoms, your vital signs, so how your blood pressure is, and then how you're currently tolerating your other heart failure medications.
Okay, that was excellent, an excellent rundown of what we do. But there's one other thing that I kind of want to reinforce here is why do we choose these medicines? And it's interesting because 20 years ago we really didn't know what we were doing with heart failure. All we knew how to do was get fluid off of people, but we really didn't understand the mechanism behind what was happening. Over time, we've kind of sorted it out. So basically, heart failure is your fight or flight responses turned on, right? So let's say you're being chased by a saber-toothed tiger, right? There are things that you would like to have, right? So you would like to be holding onto your fluid so that you don't get dehydrated while you're running. You would like to have a super high heart rate so that you can get a lot of blood pumping and keep going. But with heart failure, it turns these things on, but it never turns them off. So when you're sleeping, you don't need to be being chased by a saber-toothed tiger, right? So all of those things become maladaptive over time. So in the beginning, they're super useful, but over time, they become not useful. And so that's why we block them. And these are 3 different medications, the beta blockers, ACE inhibitors, aldosterone antagonists, that go at that fight or flight pathway from different angles. And that's the reason that we chose those and did the studies on them in the beginning. Okay. All right, so we did all this. We got him all tuned up with good medications, and things clinically improved at the time. And this is something that we see. If you can take somebody who's sick and decompensated and get them on really good medications and get them on good diuretics and get them back to where they don't have extra fluid, then they feel better and they do better. But unfortunately, the heart function did not improve. So with a lot of people, what we see is actual improvement in the pump function. So the pump will go from like not doing very much to really almost back to normal. But in this case, it didn't. But he still felt well and did well, which is why I don't judge people based on a number. I don't look at you and say, oh, you're a 37% ejection fraction. Your life should be this, this, and this. Because even with a low ejection fraction, with good medical therapy, you can live a really full life. Okay, so the next step is something called a defibrillator. And I'm not going to spend a lot of time on this, but I'm going to just say this very shortly. People that have a really weak heart are at a higher risk of having bad heart rhythms, and these bad heart rhythms can kill you. So this can cause what we call sudden cardiac death, and it's exactly what it sounds like. So what we do is if we have given you all of the good medications and got you really optimized, but after 3 or 4 months your heart is still weak, then we put in something that can save your life, right? It's like having an ambulance that rides around with you all the time. It has a little wire that sits inside the heart and it just listens. And if nothing's going on, it doesn't do a thing, just listens. But if you go into a bad heart rhythm, there are several different ways that this device can get you out of that heart rhythm and save your life. And ultimately, if it can't do its magic, it will shock, which is exactly what the paramedics would do if they were there in the ambulance in front of you. So that's the next step. We don't do it necessarily to make things better, but we do it to save your life. Okay. And again, did well for about 2 years, living life, doing what he was doing. So, you know, what impressed upon me when we were talking is that, you know, he's a house painter, and, you know, that's an active job. You know, that takes a lot of energy. And what he started to notice is that he was having more trouble. He had to stop earlier and wasn't being as productive. And then from there, started to notice the other symptoms, the swelling, the shortness of breath. Okay. So this is where heart failure takes a turn. So I have a lot of patients that I can get to this point where they are on good medications and they have a defibrillator and they're having great quality of life and things rock on like that for 10 years. And that's fantastic. But oftentimes at some point there is a trigger. Something happens. We may never know what exactly it is, but something happens, there's a trigger, and we get decompensation. And that decompensation then can be like a snowball coming down the hill, right? So then he started to have hospital stays, and they were quick, they were fast. So 1 in November, 1 in December, 1 in January. And by that time, things were looking like we needed to talk about advanced therapies. Colin, do you want to say a few words, since Jocelyn's not here, about advanced therapies? I have a slide.
So when we talk about advanced therapies, we're typically, there are several things that we're talking about. It's just an umbrella term. And advanced therapies is the term that describes the stuff that we can do if someone is not doing well despite all the stuff that we've talked about previously. So most people, the vast majority of people with heart failure, would get medications, they'd get diuretics to keep the water off, and they'd be followed by a heart failure clinic, but some people just don't do well. So I think on the screen here they show a big bottle of dobutamine. Dobutamine is a medication that's only provided in IV form. We use it in the hospital a lot. If people, what it does is it's basically a kind of a rocket booster, and it causes your heart to beat stronger, beat faster, and it provides a little extra oomph if your heart's not strong enough to provide blood flow to the body on its own. And we do that with people in the hospital who aren't doing well, and a lot of times they improve. Their heart starts beating better on their own once we get some fluid off. There are a small number of people where that doesn't happen, and they might need to go home on a dobutamine pump. There's a little pump that we can pump it in IV constantly. That, I'll have to say, is usually a last resort because people, although they feel better on this medication, the mortality is higher. There's a higher chance that they die because they're on the medication. It can cause arrhythmias. So we use this only after the other therapies. We have something called a left ventricular assist device, and this is a little pump that we can implant with it's a major cardiac surgery where they'd open the chest wall, and they'd implant the pump. And part of it is there's a tube that comes out of the left ventricle, which is the pumping chamber that pumps to the body. It goes through the pump, and the pump speeds the blood up, and it ejects it out another tube that goes to the aorta, and that goes to the whole body. So basically, this is just something that would augment the heart's own function, and it's approved for people who have persistent shortness of breath, either at rest or with just minimal activity despite medications. This is something that we're not doing at Billings Clinic right now. We may in the future. It's done typically at big university medical centers, and we work very, very closely with the University of Utah to do these. We have quite a few patients who have these who live in the Billings area, though. So I'm not saying that you have to go there and stay there. You can come back to Billings. We can follow these people in our heart failure clinic, and we can manage this ventricular assist device. It typically is attached to a battery pack that you wear, and we can change the speed of it and different settings and try to make sure that the settings are compatible with people. So this is shown to make people stay out of the hospital, symptoms better, much better walking distance and walking speed, and it even improves mortality. So very, very good devices. They don't come without their problems. There are some risks that we run into, such as bleeding, some strokes, and those are, as we come with each iteration of the device, those are decreasing generally. So the newer devices are better than the initial devices. So very good if you have persistent symptoms. And then transplant is something we also talk about as an advanced therapy. And this is for somebody who meets specific criteria where their heart's not working. They're generally somebody who has good social support so they can manage all the different issues that go along with the transplant. They're people who can manage their medications, and they don't have any other comorbidities that would limit their life expectancy. So it's a small sliver of people who are eligible for a transplant, but a transplant can also be life-changing. So we'll do that as well in a small segment of people. Sometimes we'll use a left ventricular assist device to bridge to a transplant. So we'll put the ventricular assist device and somebody will be on that until a heart's available, and then we'll implant the heart and take the ventricular assist device out. Other people have the ventricular assist device, it's called destination therapy, where they're not expected to get a heart transplant for various reasons, but they'll continue to have that device that helps their symptoms indefinitely. So I think that's about where I'd stop as far as advanced therapies go. Probably.
Yeah,
There are other devices we could talk about, but most of those are not terribly mainstream.
So I have two models of the left ventricular assist device that I'm passing around. And what I want to kind of tell you about that's the pump part. So the part I'm passing around is the actual guts of the pump. And that sits right into the tip top of the heart right here. It sucks blood out of the ventricle and puts it back into the aorta. There's a little tube graft that's not on that pump, but that puts it back into the aorta. So that's what you're looking at that I'm passing around. Okay. So we sent him to Utah, and all of the workup was done for all of these options. Dobutamine was used, and actually, we were able to get enough fluid off, and things got better. We were able to turn off the dobutamine, and he came home to Billings. So now things are looking pretty good. I think they're looking pretty good. So he came to see me, and then we discussed the possibility, which I'm going to talk about quickly because I want to leave a lot of room for questions. We discussed the possibility of an ambulatory pressure monitor implant, and this is the newest technology that we have that has really shown to help people stay out of the hospital and decrease mortality by being able to manage patients based on the pressures. So this way we can actually read the pressures and know what's going on. And that's what this is. Do you want to say a couple words about it?
Sure, yeah. So this is something we're implanting here now, and it's a neat little device. The reason that this device is available is because there's a clinical need, and that's that if you go to any heart failure clinic, and I guess I'll preface this by saying that this is actually, of all the places I've been, probably the most well-organized and best-run heart failure clinic of anywhere I've been. And we just have very, very good support from nurses, pharmacists, doctors, and everyone works really well together. But you can have a well-run heart failure clinic like that. Same thing can be said of any university system, Mayo Clinic, Cleveland Clinic, We can put people on all the right medications. We can have them call us every day, report their weights, and people still get hospitalized. You can't prevent all the hospitalizations. Part of that is because if you look at the accuracy of physical exam for detecting if you have too much fluid on your body, it's not very good. Some people that's pretty obvious, and other people tend to hide fluid, and they get out of breath, and they wake up at night and they're short of breath, and we still don't see any swelling. We don't see any obvious physical exam evidence of that. So we do know that there is a kind of a continuum of things that happens when your body is not pumping blood well and you're building up fluid. One of the first things that happens is that pressure we were talking about, because of the fluid overload, the pressure in your heart increases. And a little while later, a few days later, maybe people start to notice shortness of breath. And after that, it's maybe even a couple weeks after that where they start to get swelling and fluid buildup. So a lot of times the symptoms and the signs that would bring people in and the weight gain that would bring people in actually trail the initial signs that they're not doing well by a couple weeks. So if you can implant a little monitor inside the heart, or it's actually inside one of the arteries in the lungs, and detect the blood pressure in that pulmonary artery, the artery of the lung, then that can tell us, that mirrors how much fluid's in the body. And so if we see somebody who's maybe eaten a salty meal and their fluid is building up, we're going to see that pressure rise, and they might feel fine, but we detect a pressure rise, and we can give them increased water pills or some other therapy even before they know they're having symptoms. So they've actually tested this, and they compared people managed by a well-run heart failure clinic alone, so it's standard therapy with adding this device. And this actually results in a decreased hospitalization of about 37% overall. In certain groups of patients, it cut the hospitalizations in half. So the goal is that people end up in the hospital less, people aren't as symptomatic, their quality of life is better. It hasn't been shown to decrease mortality, but it does improve the symptoms that you get from heart failure. And so that's the goal. After we implant it, that's the easy part actually. The more difficult part is done in a heart failure clinic by the nurses, and we have a nurse practitioner who helps look at the numbers that we have all these people with cardiomems, and they each report numbers on a daily basis. So we have to sift through those numbers and see who's going up, who's going down, and who's stable. And if somebody's going up, we have to call them and tell them, hey, take more Lasix, change this medication, and then monitor for a response. So it's a really good system. We're kind of, we're in the phase where we're still feeling out how this is going to work, but there's definitely some benefit in this device in a specific subset of people.
Okay.
Is that put in the pulmonary artery?
Pulmonary artery, yes. Okay. All right. So the plan, obviously, is to stay out of the hospital. And how do we do that? So that's the bread and butter of what we do every day, and that is our heart failure nursing team, who I cannot say enough good things about. I mean, there is no way that this program would be successful like it is without how hard our heart failure nurses work for us. And our heart failure nurses, the majority of them are certified heart failure nurses, so they really know their stuff, which is, that's wonderful. I'm going to have Lisa talk a little bit about what she does.
Thank you. I see some people in the audience that we've actually talked to a few times, but our primary role is to teach you how to live with this and how to monitor if you're having worsening symptoms or if you're starting to build up fluid retention. And a very good tool with that is to weigh on a scale every single day, same time of day, same amount of clothes for the rest of your life. And people go like, rest of my life? I don't want to see how much I weigh. But it becomes important. It's something that's relatively easy, and we can trend your weights. And if you're having a sudden weight gain, 2 or 3 pounds overnight or 5 or 6 pounds in a week, then that's one sign that you might be holding on to fluid. And then we also teach you to monitor for these symptoms that everyone's been talking about, being more short of breath during night, having maybe even problems with your appetite and not feeling well with nausea because you don't feel like you can really eat. You're getting full early. Monitoring your legs, looking at your legs and your tummy. Are you getting more swollen? And then the team is someone you can call if you're being managed by a cardiologist, but if you're not, you can actually call your primary care doctor too, because they manage this, and they can help guide you and direct you with what to do. But very important to pay attention. We teach you that, and who to call, when to call. We also teach you about your activity levels. We don't do cardiac rehab, but we teach you, kind of guide you with that. And then we also teach you about changing your food intake and your fluid intake. Salty food and water love each other in your body. So if you eat a lot of salty food, you're going to have more problems with fluid retention. So we recommend that you follow a 2 milligram or 2 gram diet with sodium, and also limit your fluid if you're a big drinker of fluid. Encourage you to go out to your grocery stores. Every food that's in a can or a package or a box has some sort of sodium or salt in it. I was cooking with eggs this weekend and just happened to look at the label and went, this egg has 70 milligrams of sodium in it. And even I didn't know that, so I learned something new. So when you're out at the market or the grocery store, start looking and seeing what you can do to modify your salt intake so that you're not retaining fluid. We have a couple different ways that we work with patients. They can call us on the phone, and we also have a telemonitoring system that you can call your weights and symptoms into us, and then we'll make adjustments that are guided by the rest of the team and the physicians and nurse practitioners. And then also if you have a device, there's some ways to tell if you're building up with fluid. But most reliably, you know how you feel, and pay attention to how you are doing, and let someone know if you're not doing well.
Okay, thank you so much. So the last little piece of this is knowing what your social resources are as well. Our social worker unfortunately couldn't be here today, but we do have a support group for heart failure, and I have flyers in the back there on the table. It's a great group, and especially if you or you know somebody who's struggling with this diagnosis, it's a wonderful resource to have.